Welcome. Today we're going to discuss a little bit about resident education and point-of-care ultrasound. Few disclosures, sometimes I get paid to teach about ultrasound. Now the reason that we're all here is the ACGME rollout of the milestones, and specifically in emergency medicine. One of the subcompetencies, PC12, is goal-directed focused ultrasound. You can see there's level 1 through 5, 1 being what you should have when you enter residency, level 4 being where you should be when you graduate, and level 5 where you should be as an attending who's been in practice or reaching advanced and expertise level. Now, we may not all agree with some of the milestones in this subcompetency, but this was a first draft and it's a working model, so it is going to be changed over time. And you can see on the bottom there's some suggested evaluation methods. You can use the OSCE, SDOT, videotape review, etc. And we're all involved with education of residents in ultrasound or medical students. We're all teaching people. That's part of why we're here. But when you assess people, this brings up a whole different paradigm. And some of that is involved with Miller's framework for clinical assessment. And you can see this pyramid that we assess people's level of knowledge at different levels, bringing them up to the level of what he calls does. So it starts off with knows, knows how, knows, shows how, and does. Knows is just facts. Knows how is application of those facts. You know how to apply those facts. Demonstrates mean you can do, and perform meaning you perform. You are out there practicing medicine. You are providing care for your patients, and you're using ultrasound in a clinical method. Now, there's been documents in the past about how to train residents, how to educate them, how to evaluate them, and most commonly, a combination between several organizations, most notably CORD and SAM, or the Academy of Emergency Ultrasound. We got together and we created this document about the milestones and how to meet those milestones and how to evaluate people. And we talked about education and a resident rotation, beginner track, advanced track, timing of the rotation, teaching them core versus advanced skills, and a little bit about evaluation on these different milestones. And they're all in the document, and I won't belabor this more. What I do want to talk to you about a little bit is about how getting people to that level of performance where they can do ultrasound. How do we get them educated to that level? And part of that is also the evaluation and that feedback loop, but also how do we get them there? Now, this is from Erickson, who talks about mastery and education and leading to what we call expert performance. And that's where we want our learners. We want them at the level of expert performance. We want leaders in the field. We want people who are doing very, very well. When you think about certain tasks that we all do, shoelaces, standing up from a chair, and driving, some of these are our everyday things. And the problem is, when you start to do everyday things, you develop this level of automaticity. So you know how sometimes when you're driving home and you're not necessarily paying attention to everything you're doing. You're not paying attention to your pressure on the gas versus the brake. You're deciding, I'm going to stop, I'm going to go. You tie your shoes, you get up and out of a chair. And the problem with that, with automaticity and that effortless execution, is that accumulated experience will not really be related to any higher levels of performance. Are you better at standing up out of a chair today than you were a year ago? Can you tie your shoelaces a little better now than you could a year ago? Probably not. We're probably all reached this level of everyday skills. Some things like driving, maybe we hit that arrested development. We got a little better, but now we're just kind of doing what we need to do to accomplish those tasks. We don't really reach that expert performance level. We're not Mario Andrade. So to reach that level, you need a well-defined task with a specific goal. You need to be motivated, you need feedback, and you need repetition and gradual refinement to get there. And that is what we term as a whole deliberate practice, and that's part of it. This is where it began. You need deliberate practice to reach that expert level. And the fallacy that we have with training, Rosenberg talks about, is that there's this level of proficiency or competence. And what we imagine happens is that we train people and we teach them and we have these hands-on sessions and we're educating them, we're talking with them, we're showing them stuff, and we get them to this level of competence or proficiency. But we really don't. We get them close. We get them better than they were. We give them education training. Now, after that training session, there's one of two things that can happen. Without support, they kind of plateau and eventually drop off and those skills degrade. With support, those skills improve and they continue to improve, and post that initial education with support and help, they then reach proficiency and competence. And that's what we're going for. Competence, proficiency, and eventually expert performance. Now, what Rosenberg terms as support is really post-training coaching, a social network of collaboration, access to a knowledge base, performance support tools, and making sure that training matches your work. And all of this sounds very similar to what we call deliberate practice and making sure educational environments match. So we're not teaching you how to perform intubations on neonates to train you how to intubate adults. So the training has to match what you're doing. Now, my argument for this and what we want to focus on today was simulation and social media as methods and tools to help you with this. And not necessarily to tell you, hey, simulation's great, social media is great, but to kind of show you why these things are important and how you can convince other people at your institution, namely the people who need to help you achieve these goals or cut checks or funding or time, why these things are important and why they have value to your residents and to your program. So let's start off with simulation. Simulation, if you look at this study back in 2011, they looked at traditional clinical education versus simulation-based medical education with deliberate practice, or SBME with DP. That's what that notation means. And in all these studies, simulation with deliberate practice performed better than traditional clinical education. So it seems like a no-brainer that we're going to incorporate simulation and deliberate practice. When you look at outcomes, Cook looked at it, and all the outcomes, except maybe for patient effect, were really better with mastery learning using simulation. And patient effect does kind of, and the reason is because a lot of things are not necessarily outcome-based right now in simulation, so these confidence intervals can be very wide because they're small studies. Same thing if you look at Ilgen, who's focused specifically on emergency medicine. And you may notice some of those parameters and those tables look familiar because they're both working together here. But even there, in our environment in emergency medicine, simulation was favored over no instruction, which teaching is better than no teaching. But when you look at it in context of all the studies, it does still favor over other instructional methods. LAC looked at education and simulation-based education to train people how to do central lines, and this was their central line workshop. So they took people with a baseline, they taught them, they used simulation-based education in a standardized workshop format. People got better, but then after time they kind of fell off. So you can see here that in the baseline they got better than that with the session, and then after a session they were still better than when they started, but not as good as right after the session. So there was some degradation of skill, which they kind of bring up in their article. And this kind of comes back to that training and that education you get them to. You need that post-simulation, that post-education support in order to reach that proficiency and competence and maintain those skills and improve. Without that support, you kind of tend to taper off a little bit. And that brings up the combination of simulation with direct practice. This allows you to get feedback from educational sources, it allows you for error correction, and it allows you to reach this mastery standard of performance. And that's why the combination of the two, simulation and deliberate practice, allow you to reach that. It's the combination of the two. Mastery learning, trainees must reach a defined proficiency, meaning they need to reach a level of proficiency, not a unit of time. So it's not that we have a simulation-based session for half an hour. We have a simulation-based session, and we're going to keep doing this until you reach a minimal level that we need. And the time will vary. So why do we want to do deliberate practice using simulation? The reason simulation helps with deliberate practice and reaching this proficiency is that it allows you to isolate the difficult aspects of that procedure, because you can't do that with a patient. The patient needs the entire procedure. With a simulator, you can focus on just the difficult parts. You can stop and give informative feedback any point throughout that procedure or throughout that step. You can stop. You can't stop a surgery midway to give feedback to the resident necessarily, but you can stop that simulated scenario and give feedback right then and there on that procedure if need be. You also allows you to correct that error in real time as needed on the simulator. And it allows them to focus on the fundamentals of the procedure, not necessarily worrying about some of the other patient care issues related in a real world environment, but focusing on the simulator and that procedure. Now, when we talk about ultrasound simulators, there's this discussion about low fidelity versus high fidelity, static versus dynamic. And what's a greater focus, and Hamstra brings this up, is that instead of focusing so much on the fidelity, focus on what you need. What does the learner need? And that's the much more important clarification of that simulator. You need the level of simulation to support the learning. If you look at Dave Bonner's program, he has the ultimate high fidelity simulator. He's got medical students. So real people are possibly sometimes the most high fidelity simulators, but there's just very little or no pathology. So if you're teaching about fast scanning to recognize free fluid, while they may be the highest fidelity, they are not necessarily the best for that learning environment. Maybe a lower fidelity simulator that shows free fluid might be better in that learning context. It depends on what your goals are. But you can set up your simulation model to benefit you as you need. And you can see here the models and the learners and the teachers are all pulling things away from that. So in that education learning environment, this is a great model. And he brings it back that the field of simulation shouldn't necessarily focus on your resemblance of your simulator to people as a fidelity module, but rather the functional properties and how that simulator fits into your educational context. So you don't necessarily need the highest and most expensive simulator. You need what's going to accomplish the goals you need for that simulation task and for your context. And that depends on what you're trying to accomplish. Are you trying to accomplish scanning normal anatomy and recognizing normal anatomy and protocols like on real volunteers? Are you concentrating on peripheral IV placement and don't necessarily need a ultrasound simulator but a task trainer? And then this brings it back to what Risa was talking about in her article, that blended learning is the integration of all these educational environments. And so you need to combine different things in order to have the right learning environment. And simulation is just one part of that. That's not the only part. That is one part. And that brings us to social media. And how do you incorporate this and how do you use that? Well, one topic is FOMED, or the free open access medical education, and a hashtag if you're using Twitter. Unfortunately, I did have to say hashtag in real life, and I apologize. But if you think this is not something that's becoming very prevalent in medical education, here's a list of a few of our core things for emergency medicine. And I focus on EM because that's where my base is. But the Society for Academic EM has a committee. The American Academy of EM has a committee on social media. The CORD, residency directors, have a committee. AIUM has a web education committee, which is really social media in its heart. And ACEP has staff members who are dedicated, whose job it is to manage social media presence. If you look at Cadigan's article, there's been an explosion. As of November 2013, there's been 141 blogs and 42 podcasts from emergency medicine. And you can see that over the last several years, these numbers have been growing exponentially. When Malin looked at how people are gaining extra education, residents, they surveyed them and looked at things. And, there's online textbooks like Up to Date, but a lot of it is social media things. MRAP, MCRIT, YouTube, Academic Life in EM, Life in the Fast Lane. These are social media resources that people are using to educate themselves. Twitter accounts in 2006 from physicians, 2013. So participation is growing, even in emergency medicine. All of a sudden there's this huge spike there. And you can see that in emergency medicine, a lot of the Twitter accounts are this dense web of people who are all interconnected with some key stakeholders in red. But why is this so important? Well, Mel Herbert, who you may have heard of, social media allows faster information distribution. These are new resources and access to information. Social media is not necessarily the resource. Social media is a tool to get to these resources. It allows you to have this flipped classroom so that people across the world have access to leaders in the field. So not only are you listening to Mel Herbert talk about something, you're listening to who he's talking about this topic with. So you're having access to these thoughts and conversations between these people on these education and medical topics that if you're in an isolated area, you may not have access to. Weingart comes back and says, now instead of reading several particular journals, which we all used to do, you can now look your Twitter feed and you'll be looking for interesting and relevant articles from hundreds of journals, hundreds of articles, and you'll be picking out what you need from journals you may never even heard of or would have routinely looked at. And this then dives into the topic of tacit knowledge. So rather than objective knowledge, but tacit knowledge resides in the individual. It's that know-how, that insight, the expertise, that tips and tricks kind of thing. And usually it's transferred through narrative. So they bring up thoughts of, you used to be in the hallway talking to your colleagues, you'd go to a conference, and this great national speaker would bring up the evidence and then tell you how they use that evidence towards their care. And that's how that tacit knowledge is transferred. But now we can use social media to do all of that. Social media allows that transfer of tacit knowledge throughout the world, not just in your local community or not just if you happen to attend that conference. Erickson, who you remember from talking about proficiency and mastery learning, goes back to say, now, mastery learning and expert performance could be improved? What if we had videos that were stored somewhere that you could review? What if we could pull that training out of the context of actual tasks, meaning instead of seeing patients or training you while seeing patients, we have another way to do that, such as simulation? What if there were a library of pictures or digitized images? Sounds like social media to me. And what if there are several alternative options to a traditional apprenticeship and model of learning, such as, say, the flipped classroom? So now Erickson, in 2014, is delving and bringing up all these contexts, and he brings up pretty much simulation and social media as ways and new ways to reach that mastery learning level and that expert performance. And it brings it all back to, remember, deliberate practice requires informative feedback from educational sources that will promote monitoring, error correction, and more deliberate practice that enable an evaluation of performance that may reach a mastery standard. So that's some of the key parts of deliberate practice that are needed. Feedback, error correction, and mastery standard achievement. That's the goal. And all of that comes back to the support. Part of that is that network and access to knowledge base. Not necessarily your own knowledge base, but the knowledge base of others to allow you to grow. And I will posit that social media and simulation increase your available resources, increase your opportunities, increase your level of feedback, and give you support for deliberate practice. And that's how social media and simulation factor into your education and growth in ultrasound. Viva la phone.